Welcome to the broadcast. So today I'm very pleased to have Emil Djakic in the broadcast studio. So Emil is a recently retired GP and former director of the Patrick Street Clinic in Ulverstone, has a wide range of experience in the health sector, not just in GPs, but also in, advice and administration of the health system. So welcome to the broadcast, Emil.
Yeah, thanks, Shane. Glad to be here. Yeah.
So I probably haven't covered all the bases. So what's the way that you used to introduce yourself when you were talking to people?
Oh, golly gosh. Very much a Tasmanian, Launceston born and University of Tasmania trained, very proud of that. And a resident on the northwest coast since 1996 with general practice as my specialty in the medical field. And yes, 30 years of that, and I've just set that aside. But in between a lot of other organisational contributions around the divisions of general practice, the Royal College of General Practice in Australia, and 6 years working with the Tasmanian Health Service Board as well. So a very diverse experience in the health space.
So you've had a long career in medicine, and not just in Tasmania. You travelled a little bit, did you? Or?
Oh, I did 2 years of my training in Adelaide to gain some experience in other areas which weren't accessible here, and some time overseas training as well, and then a year in the far northwest of Australia, so up in Derby and the Kimberley, really to go and experience remote Australia, remote medicine, and a substantial amount of Torres Strait Islander and Aboriginal health, which was a great experience. But I was a Tasmanian at heart and returned home with a growing young family and, very much a local resident.
And then you worked at the Patrick Street Clinic and then became a director?
Yeah, came back pretty well to join that team as a owner director, and spent 30 years with the team there, growing and developing it, and have handed it over now, transitioned to a lovely team who's now taking up that challenge, and now retired. Yeah.
So over that, what was that, 20-some years as a director of a practice, that practice grew a lot, didn't it? A lot of the services changed over the period. I know you tacked on extra bits, and then you had to buy the neighbours out and extend a little bit more.
I think we did 3 or 4 major renovations, and they're doing another one at the moment, courtesy of a grant out of the state government to help grow some teaching capacity there, which is very much part of our Patrick Street Clinic's commitment. I came back to that view and wanted to be part of a team that could grow a broad family medicine practice, and Ulverstone was a great place to do it.
And now you're incorporating all sorts of other services. There's a physio who works there as well at the same practice and associated with the practice, I suppose you could say.
Yeah, it was a very good collaboration to do with the Physio Tas team, and to help use some of the resources we had to expand space and bring them on board as residents or tenants in the building, but which allowed us to form lots of good working relationships and lots of good patient outcomes, basically.
So that's one thing about a GP that people probably don't see as a patient, is that how connected you are to not only other practices like physio, but also aged care, also the hospital system, also your local pharmacies, the way that you have to know and understand various systems.
Yeah, I mean, it is, particularly in our sort of regional centre, it is a collaborative team in the town, and we were very close with our other major practice in town, the Victoria Street Clinic. We collaborated with them quite frequently, and the team and doctors there, and the pharmacy network and the other players, and the aged care sector very much integrated into their services as the supporting medical service. That's part of what we saw as general practice. Of course, the hospital sector was in transition. I mean, I had my first little time up here in Ulverstone in 1992, in fact, for 6 months when I was still involved with training. At that point in time, we still had the tail end of the Ulverstone hospital itself. in its fading days as the service changed and restructured to the two hospitals, Burnie and Devonport, Burnie and Mersey.
So the Ulverstone Hospital, what sort of services were there? This was I can't remember using any service at the Ulverstone Hospital myself. So what were the services offered there? Was there maternity services? It wasn't obviously an emergency department or anything like
well, we'll go back into the days of the smaller regional hospitals. They functioned at a pretty high hands-on level. So yes, there were maternity. It was maternity activity. There was an active small operation theatre process. But by the time I was here, it was a more of a low acuity care residential facility. I think it was down to only about 11 beds or something, and with mostly been used for respite and minor ailments in the aged care group. But that became non-sustainable and sort of was further reduced and then eventually shut.
I suppose what were there? There were a number of hospitals. There used to be one at Wynyard. There used to be a greater service in Smithton. We've still got activity in Smithton, but also Queenstown. So what were the offerings like? What did it used to be like? Multi-hospitals,
Yeah, I mean, I probably just caught the tail end of that. We still have those smaller facilities. Delorain's another one in the north that's still used under the Tasmanian Health Service umbrella as lower acuity beds for people still requiring that supported care. But in our setting, quietly the facilities transitioned and then disappeared.
Yeah, and that transition, was that gradual or was that just like a dropping of a hammer?
I missed a section of it. So by the time I returned in 1996, the Ulverstone Hospital had been decommissioned completely. And
so had the Devonport Hospital at that stage too?
Now, what can I recall of I think the Mersey or the Devonport as the maternity hospital had transitioned as well completely. Yep. So that was now empty as well. So with location out to those two remaining facilities.
Yeah, so we've gone from multiple hospital campuses down to effectively two hospitals, and then the satellite services like Smithton, Deloraine and Queenstown.
I think as transport, travel and connectedness had changed, the viability of some of those facilities had clearly altered as well as the capacity to maintain a skill base in the teams supporting them. That's right across doctors, nurses and others within the hospital sector. But a big issue really continues to come down to a phrase called scope of practice.
Yeah.
And scope of practice was all about, well, what is that facility actually capable of delivering in a way that's safe for the patient outcomes. And to some extent, there also has to be an accountability on the fiscal side and what's it cost to maintain that level of productivity and safety.
You talk about low acuity. You probably ought to spell out what that actually means. So things like broken limbs or unlikely to require emergency intervention, perhaps? Is that how you describe low acuity?
I don't have an off-the-top sort of absolute definition, but very much below the life-threatening level. Categorisation in terms of acute presentations sort of sits in the category 1, 2, 3, 4, 5 type sort of scale. So the lower end of things, minor lacerations, minor injuries, minor sort of medical illnesses, very much managed in a lower acuity setting versus things that are going to require.
So back in 92 or I think it was 92 you were talking about, Ulverstone had like a surgical theatre, did it? And so what sort of things would they have done there? Sort of wouldn't have been open heart surgery, I would imagine,
no.
but they would have done.
I keep referring to the old guys, but my mentors who were still there when I came into training had been part of a post-1950s world of generalists where they had surgical skills and medical skills or internal medicine skills and obstetric and gynecological skills. So they were all very much hands-on with a range of things. So things like appendixes and minor hernias and vasectomies and stuff are all part of the remit of that rural regional general hospital for a general practitioner. But ever so gradually, those sorts of services have become more and more the remit of the specialist service, and very much in Tasmania that surgical services have been very much a part of the surgeon specialist, and then even more these days, each of the surgical specialties becomes more and more fragmented and specialised. So that even having access to a good, workforce of general surgeons for larger regional centres is getting harder and harder, and more of the work is being located in specialist centres for a range of reasons.
But haven't we also, so that's the hospital settings, but we've also sort of seen that a little bit in GPs, haven't we? There's a lot of things that GPs used to do that now are sort of pushed out in a way to specialists.
There is, but there's a lot more things that general practitioners have to do now that are part of the bigger health agenda, which is about maintaining health, initiating preventative health, rather than reaching the other end of the spectrum, which is treating illness and trying to slow or prevent the damage done by illness, disease or trauma. So in my time, we clearly went from a much more a reactive health system to treating the illness that walked through the door to being more on the front foot in trying to manage chronic illness, manage chronic heart disease, chronic diabetes, chronic gastrointestinal diseases in a way that can keep a person well and healthy and, more importantly, productive. Productivity is a big thing. So general practice is still very much involved with dealing with the acute illness on the day, but wholly more invested in that agenda of trying to get a person as well as they can be, as optimal as they can be, so that they can be a healthy, positive contribution to the society that we live in. That's a very high level idea, but it's basically what we're about. Yeah.
So you're talking like management plans, mental health plans, those sorts of.
Yeah, keeping people well. Not ignoring the need to treat illness, but keeping people well means they can continue to be valuable contributors to our community, and it doesn't necessarily mean in employed work. That can happen by being a healthier mum, a healthier grandparent, a healthier uncle who can be helping look after someone's children whilst they're off at work, their parents are off at work. There's lots of ways to contribute in society, so keeping everybody well.
So how did you over that period, did you notice a change in your patients too? So we know that people are living longer. Did you notice like an increase in chronic disease or like improvements as well as maybe going backwards in some areas? What would be your general sense of the way that people changed?
There's definitely a lot more engagement with those active diseases and in the prevention agenda. I was sort of thinking over time back in 1992, I can't recall the exact population stats, but I think the municipality of sort of Ulverstone Penguin was probably in the 15 to 18,000 range, and our practice was then seeing probably 95 contacts a day of patients. Now we're probably in the 24,000 range, I think, in Central Coast. fact check that.
Yeah, that's okay. You're roughly in the ballpark.
And we've got Patrick Street was seeing somewhere in the vicinity of 300 contacts a day. So triple the contacts with only a 25-30% increase in the population means we're now doing more work on the population than was being done before, and that work is in the area of chronic disease management and looking after and health prevention around diabetes, heart disease, particularly.
Yeah, feel free to adjust if you have to, though, Mike. So we did a podcast earlier this year with Lisa Denny, the demographer, and she talked about a long predicted, and you could actually see this bulge, this demographic bulge coming through as the baby boomers age. There's this big cohort that are getting aged at the same time, and that's putting pressure on and this is the way that she described it, putting pressure not only on our health services but on our aged care services. And governments of all stripes probably haven't planned as well as they should have for this long predictable demographic bubble of an older group coming through the system. Did you sort of see that yourself? And is that part of the reason why you're seeing this increase in contacts?
The joy of science and evidence. We became very, I think, more aware of it. And of course, not only are we seeing the tide of that ageing population with inevitably the burden of disease or age-related changes that occur, but that's impacting on the workforce that's actually also ageing and reaching the point where either illness or retirement takes them out of the picture, leaving fewer people standing to do more. That's an interesting equation.
And also the recruiting of GPs or recruiting across the whole spectrum of medical professions it seems to be getting harder. How did Patrick Street go in maintaining that recruitment of the workforce?
I just can't recall a time in the whole of my 30-year sort of experience there that it was ever easy. It's always been harder to attract people into the region. And there's always lots of long discussions about why and how. But if we looked at our regions, the origins of, we'll stick to the general practice setting. If we look at the origins of the doctors that have been in our region, even before me, they were mostly from outside of Australia. A large amount of the 1950s, 60s were a tide of refugees from the NHS. I love calling the English refugees.
Yeah, or South Africans.
Or South Africans. Yeah. So people that moved into the Australian setting and into the regional areas where they were very happy and did wonderful jobs serving. And then in my time, we've seen other countries become part of that pipeline of meeting our needs, and hence large populations across the country belonging to the sort of Middle East, Central Asia area, who are all huge complement or contributions to our healthcare system, both in general practice and in the hospital system.
So we've talked a bit about that local focus you've had, but you also sort of had a national focus with the Royal Australian College of GPs. So what was your role with them, and was that the Tasmanian branch or the national branch?
I spent my last sort of 9 years involved with a national committee with the College of GPs in the area of health system reform and funding reform, and that was a very high-level committee of people across the country who were contributing to policy in the general practice space and engaging with governments, because general practice particularly sits within predominantly within the Medicare space, which is a federally administered organisation. And so we had to work with delivering suggestions and solutions and policy influence to try and work on the issues of workforce and sustainability I convinced them to switch the word from sustainability to viability, which has been taken up. And to some extent, that work of that committee was taken to heart by the government current regime in their responses with changes in Medicare to reinforce the funding base from Medicare, particularly in the general practice space, because the alarm bells were well and truly ringing, and this was in the nature of the transition of our own university-trained doctor graduates who were more and more choosing not to follow the generalist general practice pathway. So the estimates were for replenishment of the general practice workforce required somewhere in the vicinities of the 40% territory of those graduates to choose general practice. And the number that I last heard, and this was in the last 12 months, was it was down to around 15%. And there are lots of reasons why our graduating young doctors were choosing not to perhaps follow that pathway. On interviews with that cohort, one of the largest ones was them looking at financial security over time. But as you move out further away from the major centres, there was a multitude of influences that are making it very difficult for some of our newer doctor graduates, our Australian-grown, Australian-born ones, to choose to find an alternative pathway in the health system down the specialist path, and frequently find themselves living in the urban centres in the cities. This great big wide brown land of ours is, I think, one of the most urbanised populations in the world.
Yeah, ironic, isn't it?
We're a paradox.
Yeah.
We keep loving the sunburnt country, but unfortunately, as long as it's at the beach in Sydney.
Yeah. And then once they leave Tasmania to specialise in whatever it is, it's hard to get them back. They partner up and have all those other stresses and strains that make it difficult to come back to regional areas.
The equation gets more complicated. We are seeing the medical schools around Australia now are predominantly what we call postgraduate programs. That means rather than going straight from your year 12 into university and medicine training and falling out the other end 5 years later, they're choosing to be taking on board people who already have a degree. It might be in nursing or physio or some other science-related areas. So they're arriving into the medicine course already probably aged 21 or 22, and then doing their 4 or 5 years. So they're on average older. They're frequently, as you mentioned, already partnered up. They possibly already have mortgages, possibly already have children, and other commitments, which tends to bind them in areas that prevent them from perhaps moving away from the urban centres.
So that was what you were seeing with the Royal Australian College of GPs, but also we talk about that time spent with the Tasmanian Health Service in an advisory capacity. So that was, how did that come about? And do you want to just talk us through some of the things that you tried to achieve?
Oh, that was a really sort of exciting opportunity after some of my other work with the divisions of general practice. I had a lot of experience in governance and organisational stuff in health. The then state government elected to move the governance of the Tasmanian Health Service out into an independent committee that they appointed on application, and the initial take of that was 3 regional committees: Northwest, North, and Hobart. South, yeah. More than Hobart, isn't it? Yeah.
Well, no. People in Hobart think that is all of Tasmania.
And so for the first 3 years, it was the 3 organisations, and it was aimed at trying to look at the healthcare decisions for the administration of hospitals or the network in the region. There was a lot of significant people involved there at the time, and there was a lot of interesting and challenging work to do to try and set an agenda both within the remit, and that is the budget that was available, but also trying to look at saying, okay, where do we take this system? And our contribution there was very much involved with the challenge that we've got in the northwest coast, and that is the distribution of our demography. So our people spread from Port Sorell to Smithton and then down the west coast, and the nature of the resources we've got, meaning they're particularly focused around the two then major hospitals. It was pretty clear that the range of services that were being offered through the front door of both of those facilities was not sustainable. And particularly some high-end services, and some of that sat immediately with the Mersey Community Hospital in terms of ICU and things of that nature, that just were not reaching the workload and the levels of activity to maintain skills and maintain safety.
So that's something that probably, I suppose, a lot of people don't understand, is that a specialist in a particular area needs to see a certain number of patients to keep their skills up. So do you want to just, and you talk about sustainability, do you want to sort of give an example of a service that's actually really difficult to deliver?
I think the biggie that was right up front was the intensive care service. ICU, as we know it, requires a lot of specialist skills, and to maintain those skills at a level that's seen adequately were well defined by the College of Intensive Care Specialists. So we have these national bodies there as professional bodies to really look at, well, what does it take to achieve a standard? And I think the key one in that setting was about ventilated patients, which is a pretty common thing within the intensive care.
So that's someone who can't breathe on their own, and they need like a tube down their throat or whatever.
So without assistance, they're not going to survive or be able to go through what they have to go through. And I think I'm working from memory from about 10 years ago, but the level was estimated that the minimum would have been 52 ventilated bed days per year or something like that to maintain skills. And the facility was way below that. And it was an uncomfortable thing to have to make sort of the suggestion, well, that's just not going to be viable.
But when you, we got to get into the language that people may understand. When you say not viable, you mean that if people's skills drop, there might be bad outcomes. People might die, or people might probably...
Plainly wasn't safe.
Yeah, it's not safe. Yeah. Okay.
And as a person who was involved with the governance of the organisation, so as you would be if you were running any business, the answer was, is this the business we need to be in if we can't guarantee that it's a safe business? Because accountability lies with those who are running it. Ultimately, it was the government's accountability, but we were the first line of that. So there were decisions to be made to say, well, this can't be done. The same came into the discussion around the obstetrics and maternity service, where we had specialists who were working on call 7 days a week, 24 hours a day for not months but years in a row. And there was no way that you could anywhere explain that service was going to be seen as safe. So rationalisation of that sort was on the basis of what's, first of all, front and centre, going to be in the best interests of the patients who are at risk. We appreciate that led to the need for services to be transporting a lot of patients, but ultimately the risks of not doing that were higher than the risks of those needs of transport.
So that's obviously having those sorts of discussions with government and with the community, indeed, who would much prefer to have services close by. When you start talking about whether or not they'll be safe, or whether or not which service should be in which hospital, for example, then how did that react on a political level and in a community level? There was some resistance, I would imagine.
Well, first of all, in making those sorts of decisions, we were able to look at it and say, well, how do we manage this change and discussion first? So how do we engage in a process of explaining the rationale behind the need for those changes and rather than them being just a mandated process, because we were very much aware that we were making decisions which weren't going to sit comfortably with everybody who would like to have. I'm afraid the naivety of the community was there's a sign saying hospital or emergency department, and the assumption being that therefore all the services that they expect to be behind that front door sign are going to be as they should be. And so once we as a governance body were recognising that maybe that wasn't the case, then we needed to say, well, we're going to have to come up with an alternative that's fit for purpose, safer, and in the end going to be more viable in the long term, because the viability question sits with the ability to sustain a workforce that can deliver that whole service. And that's not just doctors, that's nurses, that's technicians, that's the support services that wrap around an entire complex unit like a surgical unit or a high care unit or a medical ward and so on.
So that period of time where you had the three different bodies, was there that ended up being formed into one statewide? So was there a bit of tension between the different regions?
No. In fact, at that sort of my recollection of the subsequent conversion to the one state board was a very harmonious group who were focused on what can we achieve for the best in the statewide services, and this was a point in time where we had some very bizarre structures within the state health services. There was a point in time where we didn't have one unified health record number across the state.
So you mean like Shane brought as a patient, if I moved from Burnie to Launceston, they'd create a new number for me and not be able to track? Is that what you're saying?
Yes. Me as a GP had great difficulty in getting information out of some of the services because we had no way of utilising their system or numbers. So the reform that was required and that we were working with at pretty well that level was looking at the nature of statewide services, how to restructure information management so that was going to start to move towards a more contemporary model.
So electronic records, you mean? Or?
Oh, well, electronic records. We had plenty of electronic records. Unfortunately, it was duplicated across too many systems.
Right.
So really having one unified system for state-run services was important. Building capacity to respond to surges in demand was another big issue. Of course, that's a major one on all of the hospitals.
Not everyone gets sick on the same day. Yeah.
But there was a lack of ability initially to have a view of the whole system to say, okay, we've got a pressure point occurring at the Royal Hobart Hospital at the moment. What other capacity do we have that's underutilised at the moment that can allow us to redistribute some of the low acuity stuff? This sort of, and what became known as the ops room, and I'm not sure whether they're still functioning, but ops rooms were commenced and I visited the early ops rooms in Launceston and Hobart, and really it really was like, the nerve centre of an ability to deal with crisis and distribution. All those services clearly are under a great deal of demand, and citizens are entitled to feel like they should be able to get access to that demand to that service when needed. But the service has to run as efficiently as it can to be as effective as it can, and that restructuring was needed.
So you transitioned then to a statewide advisory board.
Yeah.
How long were you in that for?
I think that period was either 3 or 6 years of it.
Enough of the time. So what sort of sense did you get out of the changes then? So then you transitioned to have going from a regional view, going from a GP to a regional view to going to a statewide view. Where did things start? Was it an evolution, or was it like, oh, now that I can see the whole system, then there's a whole different series of change that's required?
No, I think there was a continued argument always, particularly as we came from the northwest, for the further clarification and the improvement in the delivery of statewide services. The northwest, as a GP, we always felt like it was harder to access some of the range of secondary or tertiary services. So these are the higher level specialties that we would be the first clinic to be lost, say, at the Northwest Regional Hospital when, of course, manpower became a problem in Hobart, so the ability to do outreach services. Right. So we were involved with arguing that the 100,000 people that sort of I view as the Northwest Coast remit were getting access to the right level of interest from the THS system.
So trying to avoid that Hobart-centric view or Hobart and Launceston-centric view.
Yeah, but accepting that in a changing healthscape that we weren't arguing to say things have to stay as they were or we have to have an absolute duplicate of everything that existed within Hobart or Launceston, but we needed to be mindful of creating the right pathways or capacity for patients to have access to that system. That brings us to the patient transport system, doesn't it?
Yeah, wow. Yeah, having to transport patients, like if you can't get your service. So, something like heart operations, for example, you have a heart attack and you might need to go to Launceston, or is that what you sort of...
Yeah, I mean, those sorts of things are a reality. That's where critical mass for specialist services will be, and gradually as medical care and technology has changed, that care starts to become more distributed. So I think we're still looking forward to the evolvement of interventional cardiology in the Burnie setting in collaboration with the private enterprise, I think. So it's a it's a process of developing those, but no, the system underscoring it, I was always relatively critical about was the funding to support people to travel, patients to travel to care when needed, which is this extraordinary paper-based system that they've got in Tasmania, PTAS. PTAS.
Yeah.
I think one patient of mine told me one day he got more back to travel to Launceston than he did for the return trip.
Right.
I just couldn't quite work out how the system was working. But, that was a system or is a system that's designed to try and offset the fact that getting to your neurosurgery appointment in Hobart from Burnie should not have you out of pocket compared to getting on a bus in Glenorchy to go to it in the Royal Challenge.
But there's also some services that can't even be delivered in Tasmania. You have to go to Melbourne or elsewhere.
Yeah, those services get accessed. I always found, though, that pathway quite reasonable. Of course, it required a specialist to recommend that. And that was a relationship then between state government and Victorian government mostly in terms of the accessing the necessary clinics there. Interestingly, that one seemed to function quite well. And we never ever, my GP role never ever saw, what the money was that was involved. But the patients who came back to me, said, things worked for them from that way.
Yeah. So that statewide view, that there has been change. We've seen a lot of pressure, an increasing amount of pressure on our emergency services, emergency departments, which is, we talk about bed block that's been in place for a long time. We've seen an increase in waiting lists and so on. So this, is that been your view when you're dealing with patients and you see them bounce out of hospital probably before they should? How did that change over your 30 years?
Oh, definitely. The safest thing to do is get out of hospital. That's a regular axiom to use, meaning as soon as you're well enough to be somewhere else, then the best place to be is somewhere else, whether it's in a lower level care facility or whether it's home with immediate support at home. Not just because it frees up a bed, but it's the safest thing to do. But improving efficiency is a way of the way that people get assessed and into a hospital facility, the treatment that they need, and the pathway to exit that hospital as quickly as possible, with the care having been delivered that was required, is clearly part of the whole the flow management, the lean methodology, industrial process of how do you get something done as efficiently and as effectively as you can, so that your resources are, and I learned that from one of our board members in the Northwest, a very eminent industrialist. But healthcare is no different. We won't insult people by saying hospitals are factories, but at the end of the day, they have to run with that sort of focus of how do you do each process as effectively and efficiently as you can. General practice was the same story. You have to work out what's the best way to address a patient's care in a timely and effective manner. Can't say we always got it right, but you aspire to that.
So given that, you've just it's a nice segue to probably the thought of how do we make things better, and that's something that I'm always focused on is how do we make things better. So one way to discuss that is to talk as if nothing existed and we were going to build something from scratch. What would be the best way to set it up? So the Northwest Coast, we've gone from having multiple facilities. When you first started, that was reduced down to two major facilities. Now we've got one facility in the Mersey that has reduced its service offering. We've had Burnie maybe even indeed increase its service offering. But if you were going to start from scratch, like if you said, okay, for whatever reason you had a blank slate, what would you do? What would be the way to make that efficiency, the patient experience better?
I don't think we need to reinvent the wheel. I did a visit to a colleague in Canada quite a few years ago in New Brunswick, and they'd engaged on this process. They had largish regional centres. They recognised they had difficulty retaining a workforce, retaining scope of practice, retaining the skill sets required to meet the needs of their distributed community. They literally, between three major centres, drew a bit of a triangulation, worked out where the new facility should be, built the new facility, discussed with the community the whole journey through this, built the infrastructure that allowed people to get to the new facility, but knowing that the new facility was there to do a very specific thing, and that is you went to the hospital to get something particularly done. It wasn't about the front door of the necessary lower acuity emergency. So for us, we've got something similar, except we've got a linear city. It's a challenge because our patients, our citizens are spread pretty evenly across 100, 150 kilometres.
Yeah.
I still belong to the thoughts that long-term planning needs to be focused on one centrally located secondary hospital facility. And that means scope of practice up to a level that's capable of sustaining a Category 1 accident emergency and supported by a functioning and experienced ICU and the other services that belong to that. Appreciate that that's not controversial but disruptive to a range of people. Obviously, there's a lot of employment involved around hospital services and it affects lives. But I think what we're talking about here affects lives if we don't address it properly.
Yeah.
The infrastructure that exists, and I know it's been rejuvenated and repurposed as a day hospital type facility. I think if we were to look at the lifespan of a hospital building itself, the use by date, and we're not talking about best before, we're talking about use by date.
Yeah.
I think somewhere down on a plaque buried down in there, it's probably last century rather than this century. And personally, I've never seen a site more inappropriate for a large-scale hospital development than on a cliff on the side of Burnie.
Yeah.
Every single bit of build that has to go on there must be frightfully expensive in terms of dealing with the slope and the access
The
and everything
landslip
that goes.
yeah.
So I just sort of stick in the same, stick within the brief you're asking, saying what would you do? I think I'd be looking at infrastructure that was on an area of land that was capable of dealing with all of the requirements that surround it, with the scope to grow as inevitably our communities will continue to grow, and that it can be accessed appropriately by communities with distributed hubs that function within the major population centres. And by that I mean the majority of your outpatient clinic services could be very much housed, and a lot of the current sort of urgent care clinic type stuff to be co-located in the same centre. I would have built in Devonport and Burnie a dual purpose building, one that could during the day function as the outpatient day services, and then in the out-of-hours session beyond the normal hours of the available general practice setting, the ambulant sort of low acuity care stuff.
Right. And so we also see you're talking about patients, step-down patients and the like, low acuity patients. So one of the things that they've done elsewhere as well is this idea of a Medi-Hotel. So once you reach a certain level, you instead of sitting in a very expensive hospital bed, you sit in a hotel which is very close by, if not connected to the hospital, and then you're still monitored, but it's not in a hospital setting. It's more like a hotel, and that was certainly the case. I think in Adelaide with maternity services, you do have the baby, and then if everything's going okay, you move into what is in effect a hotel room, still monitored by the midwife or the obstetrician, or the obstetrician, but instead of costing the health system thousands of dollars a day, it's costing hundreds.
Oh, absolutely. As I said, the safest thing to do for a patient is to get the care they need at the right time in that place. And once that care is not required to be in that particular level of service, the ability to move somewhere else within the reasonable remit of that service. That doesn't mean come back to regional Tasmania to stay in a hotel. It might mean having a facility, yes, Hobart and Launceston. But the idea of getting out of hospital is it always seems uncomfortable to say, because it would be good for the fiscal balance of the hospital. Well, yes, it's a taxpayer-funded service, and keeping the costs, keeping the spend as effective as possible is an important thing. And if the spend per day in the hotel service still allows the patient to have the care they need at that time, then that's black and white.
So the reason I'm bringing that up is because I definitely had friends who had children in Adelaide and found that whole process very comfortable. So instead of being in a hospital type setting, you're in a hotel. It's a lot freer for people to come and visit and so on in those first few days. A lot more relaxed rather than in that more of a clinical setting. But
there's a lot of that sort of evolving in as well in the return to home. With the outreach services. So there are quite a few people, who are getting their once-a-day antibiotics delivered through sort of intravenous lines or PIC lines and like, because that's all that they really needed. Go back 10 years ago, 12 years ago, they would have been in a hospital bed for the duration of the course. But if someone's getting 6 weeks of antibiotics intravenously, that's just not going to stack up. So building a variety of solutions that allows the person to get the care they need within the safest environment they can.
So the other thing that we're seeing in hospitals more and more is that the aged care patient, the bed that can't be found in the aged care system means that there's a bed in the hospital that's taken. So I know I've had constituents come in and talk about one just recently, mother's in a bed in the Mersey, and they can't find a bed in an aged care service. So they're basically in a non-aged care setting where they should be in an aged care setting because we don't have the capacity in aged care as well.
Yeah, it's a difficult conundrum to match up. Of course, the concept of expanding bed numbers in hospitals and in aged care facilities is a long game type thing. So it sort of tracks all the way back around to the use of the demographer evidence and science to be adequately projecting what's happening. And of course, it's very difficult because the landscape of healthcare is changing. But these numbers around the population and the needs, I think the numbers around cognitive impairment, so the dementia patients and things are set to skyrocket. We've got a lot to look forward to, Shane, haven't we? I think.
So what happens if a new facility also had almost like a transitional aged care service associated with it as well? So you've got the hospital setting, you've got sort of like a Medi-Hotel, and then you've got an aged care. And so that patient, instead of being in a hospital setting, as in something that's a bit closer to an aged care setting, waiting for that aged care place to open up.
That, of course, needs to not reek of cost shifting. That sounds nasty, but at the end of the day...
that is something that we'd have to talk with the federal government about.
Yes, I'm all for we'll call it the more decentralised care. Looks like we're moving back to regional hospitals, aren't we? But the need, and I think in my time, the aged care facility patients that I was seeing, the level of acuity that we were looking after in those facilities had increased. The duration of their stay was greatly reduced, not because of poor care, but they were arriving at the aged care facility in a more declined state of health, with more active progressive illness, and their tenure of surviving in an aged care facility was actually quite reduced. Now, that was partly because we've got more support from My Aged Care, federally funded support for patients in their own homes, and so they're being sustained for longer there. And by the time they become unstable and then end up either in an acute hospital or an admission into the nursing home, they're quite a lot sicker than they would have been, which means the acuity of care that is now required within an aged care facility is continuing to rise, and as such the demands and the costs required to help support that is rising, and the system's not doing a great job at, I think, accounting for that. And the aged care facilities, and I have great admiration for the aged care facilities that I was involved with in the terms of their commitment and the work they did, but it was getting harder and harder to deliver what are low-level medical care rather than just residential care.
And we're also seeing increased needs, and I know that dementia patients, for example, they can go through a phase where they become quite violent, some of them, and then that is something that's very difficult to manage, needs specialist care, but then it passes. It's a phase. So is that sort of thing increasing the...
Oh, look, the challenge
pressures
of dealing with those patients with cognitive change, so dementia being the major one. Again, in my patch in Central Coast, we were very fortunate to have quite progressive dementia services and care in the units that were embedded in each of those facilities. But there was still a need for upskilling of staff, adding of additional resources to help support the patients in those facilities who were experiencing those sorts of changes, as well as significant downward pressure coming from the Royal Commission about the nature of how those sorts of illnesses should be managed, with a total disrespect for the recognition that the resources in the regional Australia just weren't available to do all of those things that would have been, best practice. Well, our facilities were very much endeavouring to deliver best practice, but at the end of the day, if the funding's not on the table to allow those services to be fully formed to meet all those needs, it's a struggle.
So one of those issues that you face probably your entire career is the cost shifting between federal and state governments. Obviously the federal government has the Medicare and aged care, whereas the state governments run the hospital system. So has that improved, or have you seen like things come and go? What's been your experience there?
You want us to solve something that's been there for 125 years, don't
Well, how
you?
would you? I mean, one
Yeah.
suggestion was a complete takeover by one or the other. I mean, Tasmania would be probably one of the better services to be able to trial it due to our scale, but that's something that I think Kevin Rudd might have been sort of hinting at that, but came up with every government thinks about it and then comes up with a compromise that the states sign up to, and you get another 4 or 5 years of stability.
Yeah, look, this speaks to the lack of vision in terms of, and we're talking about vision that must extend out to the next 50 years instead of the very short-termism we've been stuck with. Restructuring systems and designing systems that can be seen as an investment in an outcome. And I know it sounds strange to be investing or thinking of investment in late-stage aged care, but if we can do that as efficiently and as effectively, then the patient benefits, but also the rest of the country benefits if it's being done in an economically more feasible way. So I think restructuring the whole model, it's a huge thing to engage on, but I think we need some of our very clever technocrats to be a bit bolder and a bit more imaginative in saying, well, it's time to tackle that.
Change is hard. That's certainly the case in the health space. So scale is something I think that people struggle to grasp. So the state budget is around, I'm just doing round figures, around $10 billion. The health budget is approaching $5 billion a year. So for example, we're talking about what we want the health system to look like, and you sort of put that figure in 20 to 50 years' time. The investment in a new facility, so a brand new hospital, when you compare, like that might cost $1 billion. When you compare that to the $5 billion that we're spending just on the health system every year, that building a new facility is probably not a stretch.
Yeah, look, I think it was regularly said of course, the bricks and mortar component always looks like a big ticket, but compared to the cost of services that are delivered through that facility over a duration, the actual building cost is not insignificant, but not really the big game. The biggest issue is about being able to deliver services effectively in a way that's going to lead to an improvement in the overall productivity of the region or the state. And sort of back to the preventative health agenda, if we can keep people healthier and working more productively, then that's for the good of the country. That sounds a bit altruistic, but that's the bottom line. I think you go all the way up the international world, they want 2% growth per year, don't they? Well, you're only going to get that if you've got a more efficient and effective population. So keeping people weller, getting people out of the hospital system where there is a high-end consumption of spend that goes on as quickly as possible, or even better, returning someone who's in hospital back to their productive role is a great investment, and it needs to be stopped looking at as being such a big spend. Instead, it's an opportunity to try and improve our capacity.
But if health was any other business, so if health was, instead of treating patients, was making widgets, and you needed a new building for a factory, you'd amortise that over 20 years or 25 years, but you'd be doing that to get productivity every year. So that's so instead of looking at the big ticket, look at the productivity improvements, perhaps.
Yeah. I'm no qualified health economist, and I'm sure there's some who might hear this who'd cringe at some of the things we're saying. But at the end of the day, that's what it takes is someone who can look at that future, look at this. It's hard to predict what capacities we're actually going to need, and I think a good example is related to the hospital in Burnie, where the early arguments against the nuclear medicine suite there were all very, I think, quite rapidly demanding that this wasn't going to happen, but with good fortune and some funding that was contributed, and we will respect that.
And there was a lot of political pressure too, so we have to talk about that. The named up as the cancer centre in Burnie became an election issue, and it certainly got funded.
And the end result is run off its feet.
They had to get two machines.
Unable to meet need in the end, and the facility in Launceston was continuing to be, oversubscribed. So you look back at that and you think, God, how could that not have been forecasted as a likely outcome or a likely need? And where else are we missing the opportunity to invest in order to improve not just the access for services, but improve the punch from each dollar spent, basically.
So what does the future look like then? So we've got a health system that we've talked about how to improve that. We've talked about there's one thing that people are talking about, which is sort of a back to the future moment. We're talking about GPs with greater skills. So the rural generalist model, where a GP can have extra training in obstetrics or emergency medicine and then sit in both worlds, be a GP and then also maybe perform another service at the hospital. Where do you think that's heading? And certainly, can the Northwest lead that, or?
I remain fairly ambivalent about the rural generalist model. I'll get into trouble for that, but I understand it in a more broader expanse within the remit in mainland centres, where there are hundreds and hundreds of kilometres, of travel required for some range of services. We have to accept that we've got a relatively specialist-focused service in terms of our hospital system in Tasmania, predominantly. Is general practice going to be a benefiter of the rural generalist? I wasn't really seeing the evidence of that. But I think the bigger area of change that we're going to be seeing is sitting in the information technology space. And it's not just about AI, it's about patient data related to health parameters will become more important and more distributed. I think we'll be seeing patients monitored at home. We'll be seeing consoles in the workplace that have been supervised probably by AI algorithms to then bring to the attention of the respective medical person or nursing person that's got oversight there to look at what response is required. I think we're going to be seeing we'll call it an exciting period.
Yeah.
I think it'll be a really challenging period where the match-up of information and appropriate data will change the way a lot of healthcare is delivered to that patient in that setting.
Yeah, talk about patients being monitored at home. I'm being monitored at home by my smartwatch, my Garmin. So my sleep's monitored, my pulse is monitored. You can get it to do your oxygen saturation, and indeed, like, it ranks my sleep score of a night. But the technology is getting that way that I think if you fall over, your iPhone will actually ring the ambulance.
So I think there's some. It's got to be a tool to help with efficiencies,
rather than just gather as much data about people so they can flog stuff.
I mean, I'd love to see a day where, efficient visits to your medical service needs to be able to encapsulate getting as much done in that one service at a time, particularly in the aged care space. I had the pleasure of taking my mum and dad for their flu injection yesterday in Launceston at 90 and 95. I was horrified to find that they're going to be invited back next week to have the COVID injection.
Right.
These are people that
they're not exactly getting around.
The efficiency of that process, astounded me. I think, again, back to the lean methodology stuff, which talks to a patient needs to be able to get access to care efficiently, comprehensively, and hopefully not disrupt them more than they need to be. And if some of that care can happen at home, because it can be done as a phone conversation, of course, fortunately COVID gave us one thing, which was increased access to telephony and video consults and e-scripts. So the changing technology is, I think, a very exciting, but it needs to be a tool. It's not an answer.
But we've also seen some welcome changes, I think, in the Northwest, where you can now train to be, you can do medicine based in Burnie. So one of the issues with retention to regional areas is if, like I've said, if you do your training somewhere else, it's hard to come back. But now you can train to be a nurse or you can train to be a doctor, do your medical degree here in Burnie.
Yeah, look, again, the education space right across universities is evolving with related to technology this way. So very exciting to, and I've collaborated with the Rural Clinical School through the practice for many years in a really happy, healthy way. And we're seeing real evidence of that. Celebrate my daughter this year.
Yeah, we talk about the next generation.
She's taken up GP training and started in Wynyard this year, but she came through the Burnie Rural Clinical School for a period of time and was... and now, though, if she had elected to, she could have started there first year and worked through the whole of the 5 years in that area. And the evidence is supporting that people that are continue to be trained or educated in their region have a greater likelihood of remaining within the region. Or I think even better, at least, is people that have some training exposure in regional areas of Australia are going to retain a greater appreciation for what it is like to live in a rural regional area. Even if they end up as the head of cardiology in Royal Melbourne Hospital, they'll have a better reality check about that patient they've got in their bed. So I think distributed learning through the rural clinical schools is a very positive thing. Yeah.
So in some ways, the future is looking bright.
I think it's still bright and exciting, but it needs stewarding and steering, and we need to, I think, ensure that we've got a long classic management. We've got to have a long-term view. Yes, we've got to be responsive to the short-term need and the medium term, but without a long-term journey of where we think we're going, informed by evidence and planning for that, we will continue to see a system that staggers and stumbles and is frustrating to the population because it seems that it's not working. But we have to be proud of the fact that the Australian healthcare system, and particularly Australian general practice, is celebrated around the world as one of the highest functioning systems in the world. So that doesn't mean we don't aspire to be better.
Yeah.
So I'm excited.
But in some ways, maybe politicians like myself have to work out how to work with everybody around the chamber to put that long-term plan in place rather than make short-term political decisions.
Look, how to achieve that, the ball's in your court.
Yeah, that's a work in progress.
And I appreciate the challenge of the reality of politics. I got close enough to it as in being a lobbyist in some ways. But, I think if we don't capture that, and that means, we need to be, and particularly the College of GPs needs to be, as we're doing today, talking to politicians, both state and federal, about the future. In order to hopefully complement or influence the debate that goes on.
Yeah, well, I'm hoping that this is the start of the conversation and not just a point in time. So I think we've had a pretty well-rounded discussion
Yeah.
about a lot of things, and
Good, Shane.
really looking forward to the next generation of Djakics being in the
hot seat.
In the hot seat.
I'll see what I can do.
And talk to a young doctor about the future and where they see things. That might be something.
Yeah.
But thanks for coming on the broadcast. So
thanks, Shane.
So if you like this sort of content, then remember to like and share and make comments. We're pretty happy to respond to comments. But thank you, Emil Djakic, for coming on the broadcast.
Cool, Shane.